Hall with Stroudwater Associates from our Portland, Maine office. Thank you for joining us today. First, a couple of housekeeping items. Yes, we will be sharing the materials with you as well as a recording, and I will get that out to you later today or early tomorrow morning. First, a word about Stroudwater Associates. We are located in Portland, Maine, Nashville, and Atlanta. We're a leading national healthcare consulting firm serving healthcare clients exclusively. We focus on strategic, operational, and financial areas where our perspective offers the highest value. We're proud of our more than 30-year track record with rural hospitals, community hospitals, healthcare systems, and large physician groups. Today's presenters represent all of our offices. We have Louise Bride. She's in our Atlanta office and often does a lot of work in Maine. She is an RN and a BSN. She has more than 30 years of experience in the healthcare industry and a proven record of accomplishment in developing and executing initiatives to enhance access and improve quality and cost effectiveness of healthcare delivery in public and private sectors. Doug Johnson is with us from our Nashville office, and he has a record of accomplishment in transactions, business development, and financial accounting, specifically in the general acute care hospital, rehabilitation hospital, and ambulatory surgery center space. With that, I will turn it over to the first presenter of today, which is Louise Bride. Over to you, Louise.
Okay, great. Thank you so much. Good afternoon, everyone. We appreciate your participation on our webinar today. Our topics for discussion, as you can see for those of you who are able to view the webinar online, we'll talk just a little bit about, I would like to give an overview or some background of post-acute care. What is the standard terminology? What are the levels of care? Why focus on post-acute care? What are some of the emerging post-acute care trends nationally? And in particular, we will spend a little bit of time looking at utilization and cost trends and a word about quality. And then we'd like to really spend the remainder of our time talking about these subjects from two different perspectives, expecting that we have some diversity of the participants in our audience. We really want to look at some of these themes from the perspective of the post-acute care organization itself, operational and financial performance, becoming a partner of choice. And then secondly, we also want to take a look at some of these themes from the perspective of the hospitals, health plans, and ACOs. And in particular, we will talk a bit about post-acute care strategy and goals around developing or strengthening collaborative partnerships. So first, what is post-acute care? CMS, Center for Medicare and Medicaid Services, and Medicare specifically, recognizes these four types of post-acute care. These really represent four different levels of care. So you have the inpatient rehab facility, you have the skilled nursing facility, the long-term acute care hospital level of care, and lastly, home health care agencies. And as you see, and probably no surprise for you, that the most expensive of these four different post-acute care levels of care is that inpatient rehab facility. And we'll talk just a bit more about that in a moment, but the institutional settings are, as you would expect, the more costly settings relative to home health, which would be in the community setting. I'm sure everyone has some general familiarity with the skilled nursing facility as well as home health care services. A few extra words about the inpatient rehab facility. It's not nearly as frequently utilized as the other post-acute care settings and levels of care. It is a pretty highly regulated environment. CMS has stipulated some very particular rules around the patient population, and the expectation is that an individual who goes to an inpatient rehab facility requires intensive and comprehensive rehabilitation services, and specifically the patient must be able to tolerate and benefit from, or is anticipated to benefit from, at least 3 hours per day of intensive therapy services. As you might expect, given that requirement, not all individuals would be appropriate candidates for an IRF level of care because they may not be able to tolerate that level of intensive therapy services. CMS also has stipulated what is called the 60% rule, which specifies that at least 60% of the total group of patients being seen in that facility must require IRF services for one of 13 specified clinical conditions, and those conditions are typically situations that do require intensive services. So stroke patients, spinal cord injuries, major trauma, and similar types of conditions. The LTAC setting is the other less frequently utilized setting of care or level of care for post-acute care. Again, pretty highly regulated environment, with CMS stipulating that it would be for individuals that require ongoing acute care services but do not require inpatient hospitalization. And examples would include someone who is ventilator dependent or has extensive wound care needs. I'd also like to say just a few words about swing bed services. Swing bed services are not specifically recognized by Medicare as one of the 4 levels of care, but swing beds are an important resource for Medicare patients to allow them to have ready access to post-acute skilled nursing facility level of care. Hospitals that offer swing bed services must be located in rural areas and have fewer than 100 beds to be eligible to offer those services. And I would also add that swing beds are frequently an important source of patient volume, of census, and therefore of revenue for these smaller rural hospitals. This brings us up to our first audience polling question. We are interested in knowing if you currently own and or operate post-acute care assets. And I think Kimberly will give you additional instructions about taking the poll.
Just launched it live for you, Louise. And it's a quick one, a yes, no, or under consideration. Do you currently own and or operate post-acute care assets? We're collecting. So far, we've got about 30% yes and 61% no. Give it a few more seconds for people to check in. 60% have voted so far. All right, we've slowed down, so we'll call that. And Louise, that was 33% do have a facility and 61% do not, with 6% under consideration.
All right, well, very good. Well, thank you everyone for taking a moment to do that. That is helpful to us in terms of just giving us a bit more of an understanding of our audience today, so thank you. So the next topic is really why focus on post-acute care. Why is it of particular interest for hospitals, health plans, ACOs to be thinking in terms of the post-acute care component of the continuum of care that their patients, their members are utilizing? A number of emerging trends in post-acute care that we wanted to call out today. And as you will see, and as we will discuss, they really mirror what has been happening in the other major components or other major sectors of healthcare. In particular, they mirror what has been happening on the inpatient hospital side. So an increasing national focus on post-acute care cost, utilization, and quality. And much of this really goes back to the passage of the ACA and the establishment by CMS in 2012 of hospital readmission penalties. So for the first time, really, hospitals began to have a vested interest in paying attention to and understanding and knowing the outcomes of care delivery for patients who have been discharged from their hospital and have gone on to receive post-acute care services. The rise of value-based reimbursement has also had a direct impact in the post-acute care sector, and we'll talk just a bit in just a moment about a couple of CMS bundled payment arrangements. But the onset of those bundled payment arrangements or episode of care-based reimbursement arrangements have had a direct impact. Post-acute care has had a direct impact in those new arrangements. Likewise, the planned development of the SNF value-based purchasing program has another emerging trend that has really heightened attention and focus on post-acute care. Recognition of post-acute care as a component of the medical neighborhood. You may be familiar with that terminology. It's really been born out of the focus on the patient-centered medical home in the primary care context, and thinking in terms of then the whole network of other healthcare-related services that individuals receive. So there's been growing recognition of the importance of post-acute care as a component of that medical neighborhood and as a component of the full care continuum that individuals utilize over time. And finally, and we will say more about this later in the presentation, an emerging trend related to increased collaboration, increased collaborative relationships and partnerships between post-acute care organizations and hospitals, health plans, and ACOs. And we'll talk a little bit later about the rise of preferred skilled nursing facility provider networks, and also the increased focus on both quality and utilization performance metrics that would be the metrics of the post-acute care entity, with a particular focus on length of stay and readmission rates. As you will see here on this next slide, the CMS has launched a couple of different bundled payment initiatives in the last few years. The Bundled Payment for Care Improvement initiative, which launched in 2013, offered 4 broadly defined models. The 2 that are relevant for this discussion today are models 2 and 3, which do include the post-acute care period in the defined episode of care. There are several options, or there were several options available when those models were first launched, anywhere from 30 to 60 to 90-day period for that post-acute care period as the component, a post-acute care component of that total episode of care. And phase 1 has been completed, and BPCI moved into phase 2 last year in 2016, and is continuing. CMS did announce in late 2016 that they would be extending that phase 2 through September of 2018 for models 2, 3, and 4. So again, significant component of post-acute care in both models 2 and 3. The other major CMS initiative involving a bundled payment reimbursement arrangement is the orthopedic bundle called Comprehensive Care for Joint Replacement Model, affectionately dubbed the CJR. And that bundled payment arrangement looks specifically and focuses specifically on total hip and total knee replacement surgeries. That model does include a 90-day period of post-hospital discharge for post-acute care services that occur in that 90-day period of time. Participating hospitals are financially accountable for cost and quality of the episode of care. So again, that has really greatly impacted the relationships of the hospitals participating in this bundled arrangement with their post-acute care partners in their marketplace. As you may know, the program was originally structured as a mandatory participation program, and it was a large-scale program identifying 67 geographic areas. In the earlier summer of this year, 2017, CMS announced an intention to restructure this program, and the final rule was just announced on November 30th, as a matter of fact, and they are essentially slashing in half the number of mandated geographic areas, dropping from 67 to 34, and thereby reducing the number of hospitals that will be required to participate. They are, however, going to give the previous mandated participants the option to participate now going forward on a voluntary basis. There's been a lot of speculation about what CMS's continuing commitment would be to bundled payment arrangements as these changes have been announced and now are moving to final rule status. In particular, there's been a lot of discussion about that in the context of these announced changes for the orthopedic bundle. And I wanted to share with you, because I thought it was just really helpful, in the press release that CMS announced just a few days ago on November 30th, when they announced the final rules for these changes that I've just mentioned. There was a really good quote in their own press release by the CMS administrator, Ms. Verma, that I wanted to share with you today, because I think it really gives us an indication of where CMS is intending to go as it relates to their commitment to bundled payment arrangements. The quote is as follows: "While CMS continues to believe that bundled payment models offer opportunities to improve quality and care coordination while lowering spending, we believe that focusing on developing different bundled payment models and engaging more providers is the best way to drive health system change while minimizing burden and maintaining access to care. We anticipate announcing new voluntary payment bundles soon," quote unquote. So the bottom line appears to be at this point that CMS is not abandoning the concept of a bundled payment arrangement, but they are clearly moving away from large-scale mandatory arrangements and moving to increased flexibility and to voluntary participation arrangements to allow providers more choice and decisions about whether to participate or not. And I suspect we will see and hear much more about those voluntary opportunities in the months ahead as CMS continues to roll out their next iterations of bundled payment arrangements. A few bullets here that address and really represent some important data points regarding the impact of post-acute care on total cost of care. As everyone has probably heard in multiple times and seen in multiple articles, the passage of the ACA really heightened focus on the triple aim: improving the patient experience of care, improving population health, and reducing per capita costs of healthcare. And those themes will really show through time and again as we look at some of the legislative actions, and then particularly some of the evolving reporting requirements by post-acute care entities related to cost and quality and patient experience data. The Institute of Medicine report in 2013 has been widely quoted, and in that report they identified post-acute care as the source of 73% of the variation in healthcare spending. There has also been a number of studies that have documented significant variation in post-acute care quality and outcomes, both in looking at setting of care, of post-acute care, as well as geographic variations. More recently, in September of this year, the MedPAC report to Congress again found that post-acute care had the greatest cost variation in comparison to the other major sectors of acute care and ambulatory care. So cost variation continues to be an issue as it relates to the provision of post-acute care services. And then lastly, significant dollars associated with post-acute care from 2007 through 2015. The Medicare program payments, Medicare program spending for post-acute care increased from $45.6 billion to $54.5 billion. So we're really looking at some specific spending here. And as this graph shows, when you look at Medicare spending here, it's broken out by those four recognized Medicare levels of care for post-acute care. The top line of the graph is representing skilled nursing facility spending, and as you will see, there was from 2007 to 2011 a steady year-over-year increase in total spending, Medicare spending for skilled nursing facility services. There was a bit of a modest drop in 2011, which has been followed by a period of relatively flat rate of spending since that time through 2015. And then the second highest sector from a total spending perspective would be that blue line, which represents home health. It may be hard for you to see the key, but that would represent home health, and then followed by on a much smaller scale, inpatient rehab and long-term care spending. This is just another snapshot looking at spending per beneficiary. Again, it really underscores, particularly when you look at that phase of during the inpatient stay, during what they've labeled here as the index hospitalization period, relatively flat there, but certainly some significant dollars. It's when you look at the post-acute care phase, that 1 to 30 days post-hospital discharge, where you really begin to see the variance in total spending on a per beneficiary basis, with $5,800 on the low end of the range, as high as $9,500 for the most expensive state in that particular study. And you also see the variation in terms of as a percentage of total spending in an episode, the percentage represented by post-acute care ranging from 34.4% low end to a high of 48.1%. This is another way to really look at the data. It's another cut of the data, if you will. This is looking at the differences based on the first post-acute care setting if an individual upon hospital discharge needs and moves on and receives post-acute care. So as I mentioned earlier, inpatient rehab, the inpatient rehab facility setting is the most expensive of the four Medicare recognized levels of care. And it's shown here on this graph, that third line down of the bar graph, the third bar graph is the inpatient rehab. And as you can see, total episode of care spending is greatest when there is an inpatient rehab stay involved. Again, consistent with really what you would expect with those for whom the skilled nursing facility setting is the first post-acute care setting, with SNF being the second most expensive. The other interesting thing about this particular slide is it also does show, and it is true, that patients often will utilize more than one post-acute care service upon hospital discharge. So as an example, an individual may leave the hospital, go to a skilled facility, be discharged home with home health, or be discharged home with continuing outpatient therapy. So that combination and that series of post-acute care services will then, of course, drive up your overall total expense of that full episode of care. Again, has really underscored the importance from the payer perspective, from the hospital system, the health plan, the ACO perspective, why it's so important to really pay attention to post-acute care services. in looking at the total continuum of care, and then further really analyzing the data and understanding where are your patients, where are your members going, and are they utilizing then a series of post-acute care settings, because all of that represents then additional cost of care. There's been growing recognition as well that there may be opportunities to change some of the traditional patterns. Perhaps there is opportunity for individuals that have historically gone to a SNF, a skilled nursing facility, to instead go home with home health or home with outpatient therapy services, as an example, as a way to ensure appropriate access to services, but to do so in the most cost-effective manner. This is a pretty busy slide. This actually is a slide showing specific experience of Advocate Healthcare, the big hospital system up in the Chicago area. And they looking at the full episode of care, they took a look across their 10 hospitals and did some analyses to look at what the components represented in terms of cost, and then looking at where they were experiencing the greatest variation. And so you can see that those lines at the top, the green line would be representing the period during the admission, and then the red line representing that period of up to 30 days post-hospital discharge. That's really where the variation is observed across their system. And then, as noted, they also were able to look at what the total spending, the post-acute care component of total spending looks like, and ranges from anywhere from 39% to 51% in comparison then to the national mean at that time of 43%. So again, for a hospital system or for an ACO, it may be helpful to do this sort of analysis so that you really have an understanding of what is happening with the post-acute care component and where do you experience variation. And this, the next slide is showing, again, thinking in terms of all of the different potential settings of care, levels of care for post-acute care. Where are patients typically going when they are discharged from the hospital if they require post-acute care services? And the majority are going split pretty evenly between the skilled nursing facility setting, represented by the large blue segment of the pie, and then home health, which is represented by the large orange segment of the pie. Those two components together represent almost 88% of the total discharges to post-acute care. So shifting gears just a little bit, a few words about quality measures. I'd mentioned earlier on that there's been a growing attention by CMS, not only in the hospital setting, in the hospital sector, but also in post-acute care. A couple of important pieces of legislation in the last few years that have focused specifically on quality in the context of post-acute care. The IMPACT Act of 2014 set forth and requires standardized and interoperable patient assessment data so that there is a capability then to look at data and to do comparisons of data across post-acute care settings for the first time. That's historically been really difficult to do. And also established a set of quality measures and very specific implementation timeline over a period of several years, 2016 through 2019. There has also now been a requirement established related to skilled nursing facility quality data reporting. And as you see, again, for the first time, really, CMS beginning to make that shift in the post-acute care in the skilled nursing facility sector to require data, quality data, as having a direct impact then on the reimbursement with a penalty for those facilities that fail to submit required data elements, and that is expected to kick in effective fiscal year of 2018. Separate legislation that also was passed in 2014 established a skilled nursing facility value-based purchasing program. Again, identified their quality of, they call them quality of care measures, but really specifically looking at 2 hospital readmission measures: 30-day all-cause unexpected hospitalizations, and really interestingly, 30-day potentially preventable readmissions. So are there transfers occurring from the post-acute care, from the skilled nursing facility setting that perhaps could have been avoided by identifying the individual's change of condition and initiating earlier initiating interventions and treating in place in that skilled nursing facility setting? Those will be some of the kinds of questions that will be important for both the skilled nursing facility and the hospitals, health plans, ACOs to be really looking at. And now, for the first time, skilled nursing facilities themselves will have financial skin in the game, if you will, to really pay attention to and begin to understand those root causes of potentially preventable hospital readmissions. A few words about Nursing Home Compare. For those of you who may not be familiar with Nursing Home Compare, it is a national database that was established by CMS. It is available to the public. It is available in the public domain on an interactive CMS website. And the goal really of CMS in establishing this database was to provide consumers with ready access to quality data that can be looked at, and comparisons can be made at the individual nursing facility level. A lot of detail here. I won't go into it in the interest of time, but you can see and take a look once you receive the deck, looking at some of the data sources, quality, staffing, results of health inspections, and then the utilization data that we've already touched on, and particularly hospital admission and readmission rates, which comes from Medicare claims data, all important sources of data that CMS utilizes to then set forth that database on the website. A couple of important points related to the quality of resident care component. CMS really looks at 2 subsets. So they look at and have established quality metrics for individuals who are considered short stay residents. Those would be typically individuals who go into a skilled nursing facility on a temporary basis. Perhaps they are recovering from total hip replacement surgery, or some other debilitation following a major surgery of some other nature. And those would be individuals that are then considered short stay residents. The long stay residents would be individuals who are admitted to the skilled nursing facility and have greater than 100-day length of stay. So CMS has established a separate set of quality measures looking at that subset of the population in the skilled facility setting. CMS has also established a star rating system, a performance rating system for skilled nursing facilities. You see here again some detail related to the components. They will calculate and then publicize star ratings for each of those components, as well as an overall star rating for the facility. And they utilize a scale of 1 to 5 stars, with 5 stars indicating the highest quality. So from the perspective of the hospital system, a health plan, and ACO, these are really important. The CMS Nursing Home Compare and Star Rating system really does provide you with considerable information at the individual facility level related to overall performance and quality, utilizing these specific measures and metrics that CMS has identified. So valuable resource as you are really beginning to take a look at the post-acute care, the skilled nursing facility providers who are in your particular markets or your particular service areas. And from the post-acute care entity's perspective, access to this database is very useful so that you have a way of really gauging your own facility's performance relative to other entities in your market, and also to take a look then at the comparisons to regional and national metrics. So a significant amount of really useful information is housed in that database. I'd like to shift gears a bit now and talk a little bit about from the perspective of the post-acute care organization itself. We've talked already about the fact that that CMS is really beginning to put some teeth into performance of the post-acute care sector, and is beginning to establish these quality reporting requirements, and in the future penalties related to potentially avoidable readmissions. So from the perspective of the post-acute care organization, it really does become incumbent on that organization to spend some time really taking a close look at internal operations and looking and performing then a comprehensive performance assessment. So I've made a couple of references already to how does an individual organization or a system of a post-acute care entity compare to others in their market. And so for that organization to really take a look at what is their strategic market position? What about operating and financial performance? And in particular, really looking at those same components that we've just been speaking about. So utilization, cost, quality, and patient and family experience performance. What is the average length of stay for a short stay rehab resident? What is the frequency of readmissions? And then what does that mean in terms of that organization's relationship with the hospital systems in their market? And then quality of care, we've already touched on, really taking a hard look at where that particular entity stacks up in relationship to others in terms of the nursing home compare and the CMS star ratings. And this brings us to our next audience polling question. As you see, we are also interested in knowing how satisfied are you with the level of financial and operational and quality performance data available to your organization as it relates to post-acute care services. And that can either be from the perspective of your own ability to get that data if you are a post-acute care entity, how accurate and complete is it? And then it's also important if you are on the other side of the coin, if you will, you're the hospital system or the ACO or the health plan, how easily are you able to get data to really help you to do that sort of analysis when you are looking at the post-acute care component of your care continuum?
All right, Louise, we'll give people a few more seconds. And it looks like we've got a heavy grouping right in the dissatisfied. All right, we'll close this out and show that about 36% are dissatisfied with what's available to them.
Okay, so that's helpful. Again, thank you for participating in that poll. So for those of you who have responded that you are dissatisfied, then it would, I think, indicate that there may be opportunities for you as an organization to really take a look at that and to give thought to ways that you might be able to fill those gaps and increase the ease of access to accurate and complete data to really help you to understand what is the impact of post-acute care in your continuum. The last thing I want to say about organizational performance from the perspective of the post-acute care organization, once you've done that comprehensive assessment that we have just spoken about, then the question really becomes, what were the learnings? What opportunities were uncovered? What opportunities were you able to identify that are performance improvement opportunities? And then, given the set of findings, giving thought to prioritization. What will be most valuable in terms of areas for focus that will perhaps increase your competitive position in the marketplace, or improve the utilization results that you're typically experiencing, or reducing readmissions. And then in particular, what might be some ways to increase and standardize the use of evidence-based clinical guidelines? Are there opportunities to work with your area hospitals to improve transitions of care? As I've already mentioned, are there opportunities, can you really drill down and find those root causes related to potentially avoidable readmissions, emergency department utilization? All of that really then allows you as an entity, as a post-acute care entity, to begin to really develop some action plans to move the needle, to increase your likelihood of being identified as a partner of choice, and also to raise those star ratings if there's opportunity in that area as well. And ultimately, the goal from a post-acute care organization's perspective, given all that we have talked about, given the direction that things are moving to value-based reimbursement, to really find ways to reduce costs and ensure appropriate care delivery, is that you as the post-acute care organization really want to do all that you can do to be identified as a partner of choice. And then to be able to create and communicate a compelling value proposition of why you should be a partner of choice as hospitals and health plans and ACOs are evaluating post-acute care in their care continuum. And with that, I'm going to pass this to my colleague Doug, who will talk with you now about post-acute care strategy.
Great. Louise, thank you. Good afternoon, everyone. We certainly appreciate your participation so far. We just want to spend a few minutes talking about post-acute care strategies as it pertains to owning and operating assets or partnering to provide those types of services. We believe that part of the reinventing of the hospital and the health system is the effective addition and incorporation of post-acute care service lines. And if you'll see on this next slide that there's a handful of key questions that really need to be considered. Does your organization have a comprehensive overall post-acute care strategy? Do you have the opportunity to improve the operational and financial performance of your hospital or your health system by developing a more effective post-acute care strategy, and by potentially reducing inpatient length of stay, reducing your 30-day readmission rate, minimizing your episode costs of care, and your strategic initiatives don't necessarily need to reside in-house or essentially inside of your organization. They're an important part of putting together your strategy is going to be assessing the existing marketplace and to what extent are there already top post-acute care performers in your service area. And perhaps there are underperformers. Louise talked a little bit about the star rating and the patient survey scores. To the extent that you have people providing these service lines already in your market, it'd be important to appreciate their ability to provide quality care, and also to appreciate better what post-acute care providers do your patients typically utilize, and to what types of services are are the discharging physicians discharging your patients to. So as you can see on the next slide, Louise, I think we should be on slide number 30. I'm sorry, we should be on slide number 24.
Yes, 24. We're on 24 now.
Oh, okay, I apologize, but apparently my screen is malfunctioning. Okay, good. So let's, to the extent that post-acute care assets reside within your organization, so here's a handful of key questions that we also think that you should give some thought to. Are your organization's own post-acute care facilities or established service lines, are they high performing? Are they accretive to the clinical and operational results of your organization? Perhaps post-acute care is not a core competency of your organization. And if not, then is there merit to continuing to own those assets versus exploring the potential divestiture to an independent operator who then you can collaborate with? With these new care models, with the new reimbursement models, there are lots of opportunities to collaborate more effectively with some of these third-party providers. And again, does your organization have the necessary resources to address these types of opportunities, or are there more pressing needs within your continuum of care, which make it more imperative to discuss collaborative opportunities? So I believe we have another poll question to solicit your input from. And it is, does your organization currently have a comprehensive post-acute care strategy? As you contemplate strategy, perhaps I'm stating the obvious here, but obviously that your post-acute care strategy needs to drive value, and really, we're not necessarily at the point now where we should be wondering, should we incorporate post-acute care assets into our long-term strategy, but really we're rapidly moving towards becoming of how are we going to incorporate the post-acute care assets into our long-term strategy?
You can see those results now, Doug, on your screen.
Okay. Actually, Kimberly, unfortunately, I can't. If you could just review them really quickly,
sure.
I'd appreciate that.
Let me feed them right to you. Of the respondents, we've got 33% do have a comprehensive post-acute care strategy, 8% do not, and 58% report that it's in progress.
Good. Okay. Well, all right. So I've moved on now to slide 26, and let's discuss a little bit more about or reiterate why post-acute care needs to be part of your long-term strategy. Like Louise touched on, and as I just mentioned, the new reimbursement models, new care models, they really compel the healthcare provider to take a fresh look at reinventing how and where they provide care, because post-acute care needs to be an integral component of an aligned and coordinated continuum of care. Louise talked a little bit about the Institute for Health Improvement's triple aim, which obviously the key component there is to keep people healthy, but providing a seamless experience for the patient as they traverse through that continuum of care from the primary care in the diagnostic setting to the acute care setting, and then out the other end through a post-acute care setting. That all needs to be seamless. And the third part of that triple aim was, how do we push cost out of all of it throughout the whole continuum and to be more efficient. So let's discuss just for a minute determining whether to own or to partner because obviously as you put together your post-acute care strategy, there's lots of things to consider, whether it's especially as you assess the existing marketplace, and you appreciate better if, as a hospital or a health system, what percentage of your acute care patients are transitioning into a post-acute environment. To what extent, how heavily are they using a home health care setting? To what extent are they using the skilled nursing facility? To what extent are they using an inpatient rehab hospital? And also appreciate better within your own marketplace the existing scope of services and the attractiveness of existing operators as potential partners. Like I mentioned a minute ago, as Louise talked about the patient survey results as part of the Nursing Home Compare and the star rating. To what extent are there attractive operators out there that you could collaborate with, and how much coordination is there already? And we'll talk in a minute about some different structure examples. But as you can see on this next slide, which Kimberly is slide number 27, where we can talk about partnering, some of the considerations as it pertains to partnering versus ownership, because really your own desired level of control and your desired level of investment is really going to drive a lot of these decisions regarding partnering versus owning. Speed to market is clearly going to be something that needs to be addressed. Partnering with an existing provider who already does provide good quality care and that you can develop a seamless approach with is going to be far quicker than trying to, say, build and own and operate, which can take a long time. If you do it from scratch, there are regulatory issues, there are potentially CON issues. There's a recruit and hire a staff to provide the services within an owned entity. Obviously, the capital requirements are going to be different. In an arrangement where you collaborate or partner, you can reduce the amount of capital that's outlay that's going to be needed. And you also have to assess whether or not this is a core competency for your organization, or are there other places that you need to be continuing to focus your time and attention on? There's post-acute does post-acute clinical and operating expertise already reside in-house? Because this really is the potential collaborator, the potential partner's value proposition. This is what they bring to the equation, is the operational and clinical expertise. And if you don't already have it, then partnering is a good way to efficiently add it to your scope of services. If you can't do it pretty quickly, if you can't assemble it pretty quickly in-house. I think these next two, these technology integration and quality integration, are really key. Louise touched on data, the need for data, and can data be accumulated and shared seamlessly across that continuum of care. Quality integration as it pertains to care management and transition management. And interestingly enough, there are some states that have specific reimbursement considerations that you might think of. We're up against a hard stop, but there are some states where it makes sense, if you are a municipally owned hospital, to potentially own post-acute care assets like skilled nursing facilities, because there are revenue enhancements associated with them. States like Georgia, Texas, Pennsylvania, Oklahoma, to name a few, there are states where it makes sense to give some consideration to ownership of these assets. On this next slide, which is slide 28, there's a handful of sample structures. And these are the most typical structures that you see. This is certainly not meant to be an exhaustive list. The joint venture gives you an opportunity to share financial and operational risk with an operator that brings clinical expertise. The hospital can provide, or the health system provides, a source of referrals, can also contribute clinical protocols, improvement efforts. What you typically see more often in the post-acute care setting is a preferred referral network, which is a more informal collaboration. Again, that's going to depend on the scope of services that already exist within the community. And then a model that has been around for quite some time is a leasing of beds, where you can, a number of beds and/or space in your existing facility. You can provide care inside the organization without a huge capital investment. And you still may even consider an operating partner if you were to lease beds. The last point I'll touch on quickly is divesting and partnering existing post-acute care assets. So perhaps there are existing post-acute care assets within your organization, but their operating and clinical results are less than ideal. There are opportunities to identify third-party partners who are willing, and I'll tell you, there's a significant amount of interest in post-acute care assets where buyers and operators are looking to expand their portfolio of assets and are already willing collaborators because they appreciate the fact that they need to be in order to be successful with these new reimbursement models. I believe we have a poll question coming up at this point.
We do indeed. Making it live now. Does your organization currently have or participate in a post-acute care preferred provider network? And people are already clicking away. Give them a few more seconds here.
As we wrap up this poll question, I will toss it back to Louise to wrap us up.
All right, we have, looks like most people have voted. I'm going to share that. We've got people saying yes, they have or participate in a preferred provider network. 31% say no, and 23% say it's under consideration.
Good. All right, Louise, we'll turn it back over to you.
All right, thank you very much. So I know we're close to the end of our time here. So just very quickly, there is some additional detail in these next couple of slides talking specifically about developing a preferred provider network. For those of you who are not already involved, this may be helpful to you in terms of the approach to evaluating skilled nursing facility providers, again, tapping into some of that existing data that we've already talked about, making your selections, and then really working with those organizations, as Doug has just discussed, to increase the collaboration, open up lines of communication, and so forth, with the end goal being really to improve overall care delivery and transitions of care as your shared patients move across the care continuum. We've got some information here about some specific ideas, some specific ways to really then strengthen and support communications and collaboration. Organizations have done activities such as forming joint steering committees or holding interdisciplinary team meetings involving folks from the hospital setting as well as from the post-acute care setting, particularly to discuss perhaps challenging patients. Opportunity to develop and adopt common clinical pathways so that the pathway essentially goes with the patient. They're recovering from a total hip replacement, as an example. Are there some common clinical interventions that can be put in place that then are consistent as that person moves along that recovery continuum? And we've already talked about the importance of both the post-acute care organization being able to collect and report on their performance data, establishing common reporting metrics, and then sharing data among the parties. Very quickly wanted to mention, this is an emerging model that you may be familiar with the terminology SNFist model. It really is a companion to the well-established hospitalist model in the inpatient hospital setting. It's essentially implementation of an on-site medical management team involving physicians and typically nurse practitioners who are then skilled facility-based. And there are a number of benefits, as you see here, in terms of, again, as I mentioned earlier, increased opportunity for earlier recognition of a member's change in condition, which allows for earlier onset of treatment in place, with the goal of really potentially reducing the need for that individual to be transferred to the ED or to the hospital. We have a couple of slides here at the very end that give a case study of, again, looking at Advocate Healthcare system in Chicago. They did implement what has been really recognized as a very successful SNFist model involving physicians and advanced practice nurse practitioners. And as you see here, the team of the physician is typically in their assigned facilities, the skilled nursing facilities, 1 day a week, and the advanced practice nurses 5 days a week. So you really, in this model, significantly increase then the availability, the accessibility to physicians and nurse practitioners to assist with the medical management of your members or your patients in this skilled facility setting. And then lastly, this is just some data from Advocate showing their results. Over time, they significantly increased the number of facilities in their network, in their preferred provider network. And you can see, went a little too far here, the impact on 30-day readmission rates, which dropped over this period of time, and also a significant reduction over time, looking at the year-over-year trend line of the skilled facility average length of stay. And the net effect of all this is that they have been able to realize a $45 million savings in post-acute care, and that has directly translated then into the success of their own ACO product. And that brings us to the conclusion. Again, thank you so much for your time and your attendance. And Kimberly, I will turn this back over to you to wrap us up.
All right, thank you, Louise and Doug. Well, I know we're 2 minutes over, so I'm just going to squeeze in one question that I'm super interested in, so please indulge me. What are the legal constraints around having a preferred referral network? A lot of health systems push back on the ability to direct referrals to a specific SNF due to the necessity of protecting patient choice. I'm not sure which one of you is the best one to field that.
Yeah, I think I'm certainly not an attorney, and we all recognize the fact that there are sensitivities around referral patterns and that sort of thing. I think end of the day it really revolves around care management and working with your care managers and care coordinators to make sure that, well, two things. One is that the patient has the opportunity, the patient is given information and has an opportunity, that patient and their family, to make the right choice about their post-acute care setting, but also to have the established relationships with the post-acute care provider so that you can provide a seamless transition to that preferred provider of the post-acute care services, and that there's continued coordination and communication between the acute care setting and the post-acute care setting, so that you don't end up inevitably with the recurring readmission, that the patient finds its way out of the acute care setting at the appropriate time, so that you maximize the efficiency and the ultimate effectiveness of their care. So hopefully that answers the question. Louise, if there's anything else that you would add to that.
Well, I would just add to that, because this is a really a good and really legitimate concern for hospitals or health plans as it relates to steerage and the whole idea of a preferred provider network. But I think that it can really be dealt with through to some extent through the way in which the preferences are messaged. And so one of the things that I have recommended as I have worked with clients who have really been grappling with this very issue is to really develop a script and provide talking points to staff, particularly if it's a hospital discharge planner, is how to have this conversation with patients and families. So what are they, so that the patient doesn't feel like they are being forced to go to a particular entity, but that, as Doug has talked about, that there is messaging around, we as the hospital or the health plan, we have done our due diligence. We've really looked at the data, and we identified these particular organizations as really offering high value to you as, or to your loved one as the source for post-acute care services. And so I think careful messaging and having it be based on that sort of factual due diligence are ways to really address the concerns about folks feeling forced to go somewhere without having an opportunity for choice.
All right. Thank you, Louise and Doug, for your non-lawyerly advice on that topic. And with that, I'll thank everyone for your attendance and going 6 minutes over with us. Thank you from Stroudwater, everyone here. I will be sending out a link to the deck as well as the recording. Thank you and have a lovely day.